I warmly welcome all of you to today's webinar. Today's topic is the management of drug-sensitive TB in adults as well as children. Our speaker is Dr. Neena PS, consultant pulmonologist, STDC, Trivandrum. Before starting the program, I invite Arshad sir for giving an introduction to the topic and the current scenario. Arshad sir.
Good evening, all. And Dr. Praveen, thank you. And the topic is of utmost importance as most of us in outside that NTEP purview, and even those inside are somewhat confused at times regarding the quick change of guidelines. All are evidence based, and all are towing the WHO line, etc. Still, we are at the loss at times because of the rapid change of guidelines and new information flowing in this field. So, periodical update is somewhat necessary for anybody in the field of modern medicine. So coalition is has come up with the relevant topic, and Dr. Praveen has insisted on this topic to be of most importance. And Dr. Neena, she is presently the consultant pulmonologist at State TB Training Center. She was earlier with various health service institutions like DTC, Pathanamthitta, then Punana Kota, CDH, etc. And so I think that we may, without waiting, Dr. Praveen.
Yes, sir.
Yeah. Dr. Neena, please.
Slides കാണാലോ അല്ലേ?
Yes. Video ഓഫ് ചെയ്തിരിക്കുകയാണ്.
നോക്കട്ടെ.
Yes.
Okay. Slides moving ആണല്ലോ അല്ലേ? അല്ല.
Yes.
No, not
moving.
1 second. Slides move and note. Okay, fine. Okay. We'll start. So, good evening all, respected STDC Director, the coalition team chairperson, and the senior faculties, consultants, and my colleagues. So in the next 30 to 40 minutes, I'll be discussing the topic under the following headings. That is the current scenario, the global versus Indian, just refreshing the diagnostic tools which was discussed in the previous session by Dr. Chitra, and then the treatment updates in the drug-sensitive TB. I'll be discussing more on the pulmonary TB. The extrapulmonary TB, actually it's a very vast topic. So I'll be just discussing the general principles of investigation as well as the management. And the whole topic of EPTB, actually it needs another 1 hour discussion. So I'll be just discussing the general principles only. Then the management of TB in special situations and the common adverse drug reactions with ATT and its management, and also the concept of differentiated TB care model, and a few slides on the post-TB morbidity and mortality. So every year we will have a global TB report by October-November. So actually this year's report was yet to be released. It's not at all. So the last year's report, the 2024, you can see that almost 26% of the cases, the full screen is visible, no?
Yes, visible and audible.
Let me minimize it actually. Sorry.
You're visible and audible. Full screen is visible.
Hello. The slides, I lost that screen. I lost. 1 second. So, 1 second, sorry. Slide. lower. Minimizing. One second. It's not slides are not moving. 1 second. Now it's moving, no?
Yes, moving on.
Okay. So as you can see this report, the global TB report released last year, even if you see the incidence of TB or the mortality of TB or MDR TB, you can see that quarter of the cases, all the contribution is coming from India only. And the WHO set up the NTB strategy as well. Actually, the 2025 target was to reduce the TB incidence rate by around 50%, but we could achieve only 8.3% reduction in the TB incidence. And the TB mortality, the target set was to reduce by 75% when compared to 2015 data. But so far, we could globally we could reduce only 23% death till date. So when coming to the Indian scenario, so because of all the state TB program, which has been for the last few years, we could actually reduce the TB incidence by around 16% only till date. And when you consider the TB mortality, you could achieve only 18% reduction when compared to 2015 data. And all the patients who have been diagnosed with TB are supposed to be started on treatment, but we can see that that is not happening in reality. Only up to 80%, more than 80% treatment coverage could be achieved so far. And this being the real Indian scenario that is happening right now. I would also like to draw your attention to this National TB Prevalence Survey, which was conducted in the 22 states of our country. That was during 2019 to 2021, and that survey showed that the prevalence of the TB infection in children more than 15 years, and all those people who are more than 15 years, it's around 31.4%. And they noticed that there's a higher prevalence of TB among the older age, males, malnourished, smokers, alcoholics, and diabetic patients. And the important observation that was shown that survey was 64% of the symptomatic patient, they did not seek the healthcare services, and also sought the care. There was equal preference of the government and private facilities. Actually, this survey was conducted all over the country, and this may not be the exact scenario in Kerala. Here, actually, even for a small cold, people used to go for a checkup. So the most of the cases were in Delhi, and Kerala and Gujarat. The lowest number of cases was from Kerala and Gujarat. Now, this being the scenario, we need to improve our case detection rate. All the patients who have been diagnosed with TB has to be put on treatment, and a proper monitoring also is required to prevent the post-TB lung damage and a better treatment success. So, when to suspect TB? Actually, this slide you're all familiar with. The 4-symptom complex, the patient with cough more than 2 weeks, fever more than 2 weeks, or significant weight loss, hemoptysis, or any abnormality in the X-ray. Now, this 4-symptom complex has been escalated to 10-symptom complex with additions of loss of appetite, loss of weight, chest pain, dyspnea, and fatigue is also included in the symptom complex. But even if we all know that these are the symptoms that need to be suspected for a diagnosing TB case. This is not the real scenario that is happening in the periphery or the field level. Most of the time, we see when you evaluate the field level activities, where we could most of the time we could see there's a delay in the diagnosis of TB, and most of the patients who have been diagnosed will be in the advanced phases of tuberculosis. And one thing also I want to stress upon then, that all the contacts of definitely TB, that is, it can be household contacts or a workplace contact, and people living with HIV, diabetic patients, malnourished patients, and also the patients on immunosuppressants or steroids, those patients has to be regularly screened for the symptoms of tuberculosis. But when you consider the presumptive extrapulmonary TB, the symptoms also will differ depending on the organ that is affected. So if it is a GIT problem, the patient may be having symptoms like loss of appetite, loss of weight, or nausea, vomiting. And if you check a sputum for that patient, that may not be positive. So depending on the organ that is affected, for example, CNS, the patient may be presenting with maybe loss of consciousness, seizures, or weakness or something like that. So depending on the organ that is affected, the symptoms also will be different. And if you start doing sputum for such people, the sputum may be come as negative. And presumptive pediatric TB, the presence of any of the following symptoms, even one symptom is sufficient, that is fever or cough for more than 2 weeks, loss of appetite, weight loss more than 5% in the past 3 months, the failure to gain weight in the past 3 months despite adequate nutrition, with no other apparent cause, should be considered as a presumptive pediatric TB. And if you for extrapulmonary TB, as I've already discussed, the symptoms also will be different depending on the organ that is affected. And you have to consider any patient, if you are suspecting TB in a child, always you need to screen the immediate contacts of the child, that is maybe a household contact or a neighborhood, for an active TB case. That is called reverse contact tracing. And a recent exposure in the last 2 years has to be taken as a significant exposure. And where to apply? Actually, you have 3 scenarios. You have a patient coming to you directly with TOP with symptoms of all these symptoms, that maybe it is cough, it's fever, or loss of appetite, loss of weight, whatever it be. That is, patient is voluntarily coming to you. That is passive case finding. Then you are screening for tuberculosis. That is the passive case finding. And you need to focus on the other group, that is intensified case finding. That is, the patient is coming to you for some other purpose. Maybe he is coming to the NCD clinic for a diabetic control, or he's going to the ART center for the management of retro, or it may be an antenatal patient. But if in such patients, or a patient who's going to the rheumatology clinic for the management of the autoimmune diseases, and he may be on immunosuppressants, for such patients, if he is on having some symptom suggestive TB, you need to actively search for the symptoms of TB, and also screen the patient for evaluating the TB diagnosis. And that has to be done by the medical officer itself. And the third is the active case finding, that here that actually the community health worker, he is actively searching for the TB symptoms in a community among the vulnerable key population. And who are this vulnerable population? You have actually maybe 3 groups. That is geographically, that is people who are living in the urban slums, or the indigenous tribal population, and the people who are working in high risk occupations like the miners, the coal industry, sandblasting. Maybe in our scenario, maybe in a quarry worker. The silico tuberculosis is very common here. And then the clinical settings, that is all the retro patients, substance abuse, and then our diabetic patients, CKD patients, chronic kidney disease, healthcare workers, a past history of tuberculosis, malnourishment. All these patients has to be, they are at high risk of developing TB, and they have to be actively screened for tuberculosis. Even though the patient is not complaining of the typical symptoms, you need to screen for active tuberculosis. And just a few slides to refresh the session which was discussed by Dr. Chitra last week. And you have n number of tests, diagnostic first for diagnostic TB. You have the microscopy, you have Seal Nielsen and Doramin stain, and also with the newer PCR test, that is a CBNAT, ProNAT, and the line probe assay, with which you can detect the MTB as well as the resistance can be assessed. And also you have the liquid culture and salt culture to support the diagnosis of difficult cases, as well as the follow-up of the drug-resistant TB patients while on treatment. But actually our focus of shift when we had our newer tests like PCR, the NAT, ProNAT, and the CBNAT, our focus have actually shifted. And most of the time what I've noticed is that a patient coming to with symptoms, you will be sending the sample for sputum, the sputum comes as negative, and the patient will be lost follow. And by the time he comes back to you, he might have severe lung damage, and which is actually creating even the TB, when the TB is treated and cured, the patient will be still having post-TB lung changes like bronchitis, fibrocavity disease, and also maybe in the form of supra-red fungal infection. And the patient will be a lifelong morbid. So you actually, these PCR test, actually they are diagnostic test. The screening test has to be a radiology. The patient is presenting with the respiratory symptoms, you need to go for an X-ray, so that you can early diagnose a lesion, and then you have to work up whether it is TB or something else. So at times you may have you might have seen this X-ray where there's a loculated pleural effusion. Sorry. There's a loculated pleural effusion like this, but if you send a sample for sputum TrueNAT, it may be negative. So you need to do an pleural aspiration and analyze the pleural fluid study, or at times you may have to go for a thoracoscopy and biopsy for diagnosing TB. So that is a scenario. And certain situations, the X-ray may be normal, and then you have to go for an X-ray, and there will be subtle findings like this, that is a tree-in-bed appearance, so central nodules, which will be missed in a long normal X-ray. And these are findings suggestive of an endobronchial tuberculosis, not specific for TB, but it's almost suggestive of an endobronchial TB. And at times we will have typical symptoms like typical lesions like this cavitating consolidated lesion. And this is actually the miliary pattern which is seen. The X-ray may be sometimes normal, and only when you took an CT, you will be able to appreciate this. And many times you can see that there may be only this mediastinal lymph nodes. It can be TB, it can be lymphoma, only, and there may not be any parenchymal lesion as well. Only if you do a endobronchial ultrasound and at TBNA, you may be able to diagnose a lesion. And this is another case of pleural effusion, and then this is actually split pleural sign with maybe it's a tuberculous empyema. In all these patients, if you do a sputum TrueNAT, the NAT may be negative. Only if you do the specific test, you will be able to diagnose the case. So my point is actually our focus have shifted when you have the newer tests like TrueNAT and the CBNAT. You need to actually screen with radiology. Maybe X-ray, and if the patient is still symptomatic, you may have to go for a CT or further evaluation and to confirm whether it is a TB or something alternate diagnosis. And to support this, I actually want to show this data from the National Prevalence Survey, which was done in the 2019 to 20. And this survey has actually showed that, projected that there's even patients with no symptoms, there was a significant number of patients, that is 42% had X-ray abnormality. That is a patient without symptoms, even in the survey, they could pick up lesions in the X-ray, and all those patients were turned to be TB positive also. So symptoms with X-ray also, there was 20.3% of the patients had an X-ray lesion. So this is the importance of X-ray. Actually, we need to focus more on X-rays, and the patient is typically remaining symptomatic. And once a patient is diagnosed as a TB case, you need to know the drug resistance status, whether it's drug sensitive or drug resistant. You have n number of tests. You have the expert MTB RIF, that is the gene expert, which can be used for diagnosis of TB as well as the diagnosis of RIF resistance, and also the cheaper test at the TrueNAT, which is available in all our CHCs and the district hospital level. A decentralized NAT test to diagnose the RIF status. And you have additionally, you have the expert XTR. Right now, it is not available in the program, right? Maybe it will come in near future, with which we can know the additional status of resistant status of INH, fluoroquinolone, second line injectables, nethionamide in a single test, and the line progress in our IRLs, which to support the diagnosis of INH and RIF resistance, and the soil culture and liquid culture for the diagnosis of difficult cases, as well as the follow-up of the drug-resistant TB patients. So all this was discussed in the previous session by Dr. Chitra, so I am rushing through the slides. But even if you have all these tests, what is mandatory is the universal DST. This concept also was discussed in the last session, I think. I've heard that session. It is actually all the patients who have been diagnosed with TB should be offered the test for diagnosing the rifampicin resistance. And if that patient is found to be RIF resistant, he need to have additional test for diagnosing the quinolone resistance. That is a universal DST. You need to know the resistance status of rifampicin as well as fluoroquinolones, and that has to be done within 15 days of diagnosis. And But in an Indian scenario, we have our H resistance, which is very high. INH resistance is very high. Among new patients, it's around 13 to 14%, and the retreatment cases, it's around 25%. So actually, we are offering H resistance status also to all the patients who have been diagnosed with TB by additionally sending a sample for line probe assay to IR. So we will be testing with NAT, either TrueNAT or CBNAT for RIF status. And if the RIF status is, even if it is sensitive or resistant, you have to send an additional sample in the Falcon tube to IRL lab for testing the INH resistance as well. And at times you might have seen that the patient is not responding to the usual line of management, and your culture result and the line probe assay and all the NAT report coming as sensitive. And in that scenario, maybe actually it's a bit difficult situation. After assessing, ruling out all of the causes of failure, you may have to resort to other tests. That is maybe a genetic sequencing. Right now, this is available only at NIRT Chennai right now in our government system. And you have basically two types of sequencing. One is WGS, that is whole genome sequencing, where you can know the complete genome of the mycobacterium tuberculosis. And you have the targeted NGS, where you can know the specific genetic loci with targeted NGS. Now, the WHO has also approved the targeted NGS test, like the new Bplex, MIC, and AMPOT TB and TB sec, with which a single specimen. And actually, previously, we need to have the culture isolate for doing this WGS and all. Now, with targeted NGS, we can directly do the from the sputum specimen as well. So, with a single test, you can know the drug resistance status of n number of tests like rifampicin, INH, paracetamol, and ethambutol. All the secondary drugs can be known with a single NGS. Actually, this is not for general. It is now right now. It is used only for the sentinel surveillance of drug resistance, and it is available only in the National Reference Laboratory. And our IRL don't have this test right now, and maybe in the near future, all these facilities will be coming in our part of the world also. So this is only in a difficult situations where the usual management doesn't work. Then only the patient will be subjected to this type of test. It is not for the routine testing. Now, when it comes to the extrapulmonary TB evaluation, depending on the organ that is affected, you may have to take the specimen from that particular organ. Maybe, for example, maybe if it's a lymph node, you may have to take a sample for a FNAC or lymph node biopsy. But if you're suspecting tuberculosis, in addition to a sample that is taken for the pathology test, you have to take a sample for a microbiological confirmation also. Especially in scenarios like maybe if it's a health worker or a patient who is in a contact with a DRTB, or a patient coming from a high prevalent DRTB area like Bombay or Delhi, like that. So in that scenario, maybe if it's only a single lymph node, you have sent that sample in formalin and sent for pathology, and the report comes as a TB, and you will lose that. Only a single node will be there, and you will lose a option for doing a microbiological confirmation as well as the resistance status. You can't do because only the single node was there, which was taken up for the histopathology. So if you have a critical suspicion of TB, whenever you set a sample for maybe pathology, do take a sample for a microbiological confirmation for NAT. Then just a note on the how to send the sample, extrapulmonary samples. The most important thing is you should not put the sample in formalin, and you have to send the sample in a normal saline. And fluid samples you can process in the CBNAT lab. It's in the periphery itself. Wherever you can have the CBNAT, you have the CBNAT, you can do it like pleural fluid, ascitic fluid, or CSF. All you can do it in the peripheral CBNAT lab itself. But the solid samples which require homogenization, that has to be done with the biosafety cabinet only. Right now we are processing all such samples in the intermediate reference lab at Trivandrum and Kozhikode. So that is one precaution that you have to take when you send a sample for extrapulmonary specimen. Now, you should also be very careful while interpreting the test of EPTB specimens, because the sensitivity and specificity of the various tests is also different. You can see that there is for CSF, the sensitivity of the CSF specimen is only 12.5, as low as 12.5%. But the NAT sensitivity is a bit higher, it is around 71%. But specificity is also almost very good for all the specimens. We can also see that the intestinal biopsy, if you take a colonoscopic biopsy, that the NAT sensitivity is only 32%. What I meant to say is that whenever, even if you're sending a sample and the report comes as negative, the NAT result comes as negative, you should interpret that the NAT sensitivity is a variable for various specimens. So you still can make a diagnosis of TB based on your clinical, radiological as well as pathology diagnosis. But you have a microbiological evidence, that is well and good. It will be a positive test to convince the patient in difficult situations. So always you have to make an attempt to send a specimen for a microbiological confirmation, but the it has to be interpreted with a precaution. That is, even if the test comes as negative, it can still be TB. Now, with the improved case detection and sending the specimen for DRTB detection, our case detection of drug-resistant TB has improved from 2017 to 2023. It was initially very low. And now it is improved to almost, it is not because the DRTB cases are increasing, because we are sending more samples for testing. This is the integrated the diagnostic and treatment algorithm. Actually, this was also discussed in the previous session by Dr. Chitra, just brushing up through the algorithm. I will be discussing only the drug-sensitive TB part. So all the presumptive TB patients or the persons with abnormal X-ray with or without symptoms should be subjected for a NAT examination for the diagnosis of TB as well as for assessing the refreshments. And all notified TB patients who are not offered refreshment, that is, if you have diagnosed a TB patient based on the smear status, that is, sputum smear was done, it was positive, but that you are not able to assess the RIF status. In that scenario, also you have to send a sample for a NAT. Maybe it is a true NAT or a CB NAT. And the patients who are all non-responder to any regimen, that is, the patient who is already on treatment, he is already on treatment, but he is not responding. It's having poor clinical response. That patient also you have to know the drug resistance. So we'll be offering the NAT test for all these three groups of people. And if the result comes as MTB positive, the resistance not detected, we will be starting the patient on drug-sensitive TB regimen. Simultaneously, you will be sending one sample for LPA to know the H resistance. I have discussed previously, in India, the INS resistance is very high. It's around 13% among new patients and 25% among the previously treated. So all the patients who have been diagnosed with TB, in addition to assessing the RIF status, you need to send a sample for LPA to know the INS resistance as well. So a sample has to be sent for LPA, and if the report comes as H resistance not detected, then the patient will be continued on the same drug-sensitive TB regimen. And if it comes as the INS resistant, then the patient, the regimen, the usual drug-sensitive TB regimen will be stopped, and the patient will be modified. Regimen will be modified with adding levoflox instead of INS and treated accordingly. And once H resistance is detected, the same sample will be subjected for additional test rule out the other drug resistant status as well. That will be done automatically at the IRL lab. Now, this is a diagnostic algorithm, latest diagnostic algorithm for pulmonary TB in children. All the presumptive pulmonary TB pediatric cases will be subjected for a chest X-ray. And if the chest X-ray is highly suggestive of TB, still you have to make a effort for a microbiological confirmation. If the child is able to expectorate the sputum, this sputum has to be sent. Otherwise, you can try for an induced sputum with a nebulization with 3% saline, or if the small child, you can try a gastric aspirate, and the sample has to be sent for NAT. If the NAT comes as positive, you can treat as microbiology confirmed case. If the NAT comes as negative, or the X-ray is showing non-specific shadows, you can try a course of antibiotics and repeat the NAT. And if still it is confusing, then you can go for a bronchoscopy, BAL, and the sample can be sent for NAT. That the message is that you always have to make an effort for a microbiological confirmation. And at times, if it is not feasible, then you can go for a CT test and make a diagnosis based on the clinical grounds. If there is no microbiological confirmation could be obtained. And the diagnostic algorithm for extrapulmonary TB, actually, as I've discussed previously, whenever you send a sample for a pathology specimen in formalin, always if you suspect tuberculosis, you have to retrieve one sample in the formalin and send for a NAT test. And based on the NAT test, you can decide. And even if the NAT result comes as negative, I have shown the previous slide, the sensitivity, specificity status of the various extrapulmonary specimens. And depending on the clinical, radiological, and histopathological evidences, you can still make a clinical diagnosis of TB. So basically, you have two groups of patients. We have microbiologically confirmed TB with a biological specimen positive for TB, either in the form of smear, culture, or a NAT test. Or an LPA. But if you are not able to make a microbiology confirmation and you have diagnosed a case based on X-ray, histopathology, or clinical signs, then they will become clinically diagnosed tuberculosis. You can also classify the cases based on the anatomical site as pulmonary and extrapulmonary, and based on the history of previous treatment, you can classify as recurrent TB, treatment after failure, or treatment after lost follow-up. The patient defaults the treatment and comes back after 1 month, then you can take it as a lost follow-up. And based on the resistance status of the your DRT report, you can classify it as monoresistant, polyresistant. If H and R is both INH and rifampicin resistant, you can consider as a multi-drug resistant TB. And if additional to multi-drug resistant, if it's resistant to quinolone, it is pre-XDR. And if along with that, if it's resistant to bedaquiline and linezolid, it will be considered as an XDR TB. So based on it, they can be classified like that also. Coming to the topic, that is treatment of drug-sensitive TB. The main goal is to render the patient non-infectious. You have to break the chain of transmission and also decrease the pool of infection. Also, you have to decrease the case fatality and morbidity by ensuring a relapse-free cure. And also, you have to minimize and prevent the development of drug resistance. So you have basically 4 drugs, that is isoniazid, rifampicin, pyrazinamide, and ethambutol. Streptomycin, previously it was included as a first-line drug. Now it is considered as a second-line drug only. You can consider adding streptomycin only when there is a adverse drug reaction and you need to stop any one drug, and you can consider it as a replacement drug. And also in the case of TB meningitis in the initial intensive phase, because in inflamed meningitis, streptomycin will be crossing the blood-brain barrier, so you can consider streptomycin. Otherwise, streptomycin is usually considered as a second-line drug. And these drugs have varying effects of bactericidal sterilizing activity as well as the prevention of emergence of drug resistance. And the rifampicin and pyrazinamide are the main drugs which has sterilizing activity that will prevent the relapse also. This becomes very important when you consider a drug modification due to some ADR or the patient is having some comorbid illness, and then to decide on the treatment duration, this slide is very, very important. And another thing that I've noticed is that when I've seen prescriptions from other centers that like AKT4 or FOCOX, like private medicines, when they're prescribing, I've seen prescriptions with the drugs taken like paracetamol taken twice daily, or rifampicin taken in the morning, ethambutol taken in the afternoon. That is not actually advisable. You have to take all the TB drugs at the same time to achieve the peak serum levels simultaneously so that you can get a maximum bactericidal level. Since our in the NTEP it is an FTC, we always advise to take it together only. But when you give the loose drugs, I've seen many of the prescriptions like that. So that is not advisable. You have to take it simultaneously so that the peak level attained at the same time. And you have actually 4 different groups of bacilli. You have extracellular as well as intracellular bacteria, and you have rapidly multiplying, you have intermittently multiplying, and also you have slowly multiplying. So these drugs, this INH, rifampicin, streptomycin, and ethambutol, it acts on the extracellular rapidly multiplying. The rifampicin, it acts on the intermittently multiplying bacteria so that it will prevent the relapse. And the pyrazinamide is the only drug that acts in the intracellular acidic media. And it acts on the slowly multiplying bacteria. So this rifampicin and pyrazinamide, the main drug which prevents the relapse. And so you have basically the treatment of TB is basically in the 2 phases. That is, you have an intensive phase and you have continuation phase. And this intensive phase is actually you are giving all the 4 drugs together, which is basically intended to rapid killing of the actively multiplying bacilli. And you also need to understand that untreated patient will always have some sort of naturally occurring drug-resistant mutant, and it is estimated that around 1 in 10 raised to 6 will be INH resistant, and 1 in 10 raised to 8 can be RIF resistant, and 1 in 10 raised to 14 can be both H and R resistant. So by giving all the 4 drugs, you need to prevent this rapid multiplication, this naturally occurring drug-resistant mutants also, so that we can prevent the emergence of drug-resistant mutants as well. And the role of continuation phase is to elimination of the persister so that we can prevent the relapse later on. So this is the purpose of treating as 2 phases, intensive phase as well as a continuation phase. So the regimen, you have the 6 months regimen. The initial intensive phase is actually for 2 months. It is 56 doses. We have INH, rifampicin, paracetamol, and ethambutol. And in the continuation phase, it is actually 4 months. That is 112 doses. Even though we say that's 2 months and 4 months, and the total is 6 months, it's actually the total dose will be only 168 doses, and it is actually around 5.5 months only. So even if it is a new case or a previously treated, the regimen will be the same. Previously, we used to treat as a new case for retreatment cases. That is, previously treated cases, we need to treat with the category 2, which is included streptomycin also. Now, whether it is a new case or a previously treated case, we have only a single regimen. You just need to know whether he is drug sensitive or drug resistant with the help of NAT and LPA. If it's drug sensitive TB, then it is the regimen is the same. There is no separate regimen for new and retreatment cases. And the drugs will be given daily, and also on Sunday you will have to take the medicine. And the dose of the drugs will be according to the body weight of the patient. And the drugs which is given in the NTEP is actually the FTC tablets. Even though internationally this FTC is not recommended, the NTEP program prefers it because to prevent the concealed tablet. That means you might have seen that many of the patients, when you give the loose drugs, no, the rifampicin, that red tablet, the patient won't be interested to take. Paracetamol is a big tablet; he's finding it difficult to swallow it. So there's a chance of picking up the tablet, and that is called concealed tablet. So to avoid that and prevent the emergence of drug resistance, then the program endorses the FTC tablet. And you can give loose drugs in situations where there is an adverse drug reaction or the patients are having multiple comorbid conditions and you can't give an FTC. In such situations, we can give loose drugs in such scenarios. And there is no need for extension of intensive phase. Previously, we used to extend the intensive phase. At the end of intensive phase, if the sputum was found to be positive, we used to extend intensive phase for 1 more month. That was there previously. Now there is no extension. If the patient is positive at the end of intensive phase, we just need to send a sample, repeat sample for LPA to know the evolution of acquired drug resistance. Even though we have done a DST status initially with the LPN and NAT and all, the drug resistance can evolve at any time. If the patient is not compliant with the medication, it can evolve at any time. So if the patient is found to be positive at the end of intensive phase, you need to just repeat the sample for 1 more LPA, and you can switch over to continuation phase at the end of intensive phase itself. And the continuation phase can be extended, especially in the case of CNS TB, like meningeal TB or tuberculosis and the skeletal TB. In the case of disseminated TB, you can extend up to 1 year, and that will be in accordance with the decision of the treating physician. So there is no separate regimen for new case and previously treated, and there is no need for extension of intensive phase. Continuation phase can be given up to 1 year. It is for CNS and CNS skeletal TB and disseminated TB. So this is a weight band. The single tablet, a single FDC tablet will be having, you can see a single FDC tablet will be having the INH in the dose of 75 mg, rifampicin 150, pyrazinamide 400, and ethambutol 275. And depending on the weight band, the number of tablets will be different. So for 25 to 35 is 2, then it's 3, then 4, then 5, and 6. And in the continuation phase also, you will have the same number of tablets. The only difference is that the continuation phase will not be having pyrazinamide. Most of the time, the patient will be asking whether the number of tablets will be decreasing. It's not like that. Only the content of the medicine is different. The number of tablets will be same. And you can change the tablet dose only if the patient is gaining weight. That is, he increases his weight by more than 5 kg and is crossing the next weight band. Then you can shift to the next higher weight band. For example, if the initial patient weight or pre-treatment weight was 33 kg, and now he has increased his weight by 5 kg, and now it is maybe around 33.57, 38, maybe it is like that. Then you can change to the next weight band, that is 3 tablets. Otherwise, just by increasing 34 to 35 kg, you needn't change the weight band. I think I'm clear. So the recommended drug dosage for pediatric age group, mind you, For pediatric TB, the age cutoff is 18 years. It is not the 12 to 14 year age group that we take for the OP ticket. It is 18 years for pediatric TB cutoff, age cutoff. You have disposable FTC tablet, and the FTC will be having the combination of INH, rifampicin, pyrazine. The dose is also different. For H it's 50, it is R is 75, and Z is 150. And depending on the weight band, the number of tablets will differ. And for higher weight band, you have to add an additional adult FTC as well. So this A stands for adult FTC. This one is for pediatric FTC. And for the kids, when there's change in the weight band, and that is if there's you needn't for the pediatric age group, there needn't be any quantum of increase in the weight. That is like 5 kg increase is not required. Even just 1 kg increase, that is the patient is having 7 kg, now it is 8 kg. Then the change of weight band can be applied with the next very dose itself. And all those kids has to be given pyridoxine prophylaxis, the dose being 10 milligram per day. This is a simplified format, that is in the 4 to 7 kg weight band, you have 1 pediatric dose plus 1 ethambutol separately. And likewise, this is a simplified format. And for those kids who are more than 39 kg, then you have to resort to the adult formulation. Now, if it happens that you are giving the regimen as loose drugs, that is, I have discussed no, but there's an adverse drug reaction, or a patient is having comorbid illness where you can't give an FTC. In such scenarios, you can resort to this particular dosage schedule. But for children, there's a ceiling. This is the maximum dose that can be given to the children. Now, the adjunctive therapy that can be given in TB, the pyridoxine is a one drug that is given in addition to anti-TB drugs for all the patients on ATT. And the dose being, for kids, it is 10 milligram per day. For adult, it is 25 milligram per day. And for maybe for chronic kidney disease patients or retro patients for having high risk for developing peripheral neuropathy, you can give a dose as high as 50 milligram per day as prophylactic doses to prevent the pyridoxine deficiency induced by isoniazid. And when to consider steroids in TB, you have definitely indications, that is the TB meningitis, pericarditis, and Addison's disease. You can give systemic steroids, and for TB uveitis, usually it's an oral topical therapy. And these are the definitely indications, but steroids can be also considered in endobronchial tuberculosis, where there is severe hypoxia, bronchial compression, mediastinal compression, pleurisy with severe distress, laryngeal TB, iris immune reconstruction inflammatory syndrome, and biliary disease with an alveolo-capillary block that is presenting like an IRDS. In this scenario also, when there is severe hypoxia and all, you can consider for steroids as well. And the treatment duration of extrapulmonary TB patients, in general, it is 6 months only. But in special situations like the spine TB, the skeletal TB, or the CNS TB, you have to give a longer duration, that is up to 12 months. And maybe we can extend for skeletal TB, you can increase the dose up to maybe 18 months, depending on the clinical scenario. And for lymph node and ENT cases, you can extend the dose up to 9 months maybe. So otherwise, routinely for all of the cases, that is pericardial, hepatobiliary, intestine, the intestinal and all, the routine 6 months treatment is sufficient. This is as per the extrapulmonary TB guidelines released in 2023. Now, the management of TB in special situations, if it happens that a patient was diagnosed with TB, is pregnant and lactating, we can give all the first-line drugs very safely. But the only drug that is contraindicated is aminoglycosides. Routinely, we don't give aminoglycoside, but when the scenario comes as there's an ADR, like the patient is having a chronic liver disease and you have to substitute the drug, then aminoglycosides are not recommended because it can cause fetal ototoxicity. And mind you, this anti-TB drugs, it doesn't offer any transplacental protective benefit to the fetus. And the important thing is the breastfeeding should be continued. It should not be discouraged. And but the mother has to be encouraged for cuff etiquette and barrier nursing. And the risk of transmission to the newborn depends on the maternal disease type, whether it is a very severe disease, whether the mother is on regular therapy, and the closeness with the child, and whether she is practicing the cough etiquette, and whether the child is on routine TB preventive treatment. These all will affect the whether the child will get the disease or not. And a mother receiving anti-TB treatment with INH and their breastfed infant should be supplemented with pyridoxine. And you should have to rule out active TB for the child, and TPT has to be given offered to the child. Usually what we give is 3 months of isoniazid and rifampicin. And all the children who are born to mothers with TB should receive BCG at birth because it will prevent the fatal forms of tuberculosis. Now, the diagnosis of perinatal TB, you have basically 2 main infectious routes for congenital TB. You have transplacental route, where in which case the primary complex will be in the liver, and by the aspiration, if it is an aspiration of amniotic fluid, it will be in the lung, and if there's an ingestion of amniotic fluid, that the complex will be, the primary complex will be in the GIT. And to help the diagnostic criteria, you can use the modified Campbell's criteria. That is the child getting infection in the first week of life, and there's a primary complex in the liver. And after ruling out other causes, other mode of infection, these are the general guidelines that is followed in the modified Campbell's criteria. And you need to have a good clinical examination. Maybe you have to resort to an X-ray, ultrasound abdomen, and a gastric aspirate to support a microbiological confirmation. But the difficult part is that the congenital TB almost mimic the common neonatal illness, and it's having a very poor outcome because of this, with a more than 50% mortality. And in TB patients with a chronic kidney disease, you need to calculate the creatinine clearance. If the creatinine clearance is less than 30 ml per minute, you have to modify the dose of pyrazinamide and ethambutol, which is having a renal excretion. And the drugs has to be given 3 times per week. And the dosage being ethambutol 15 mg per kg and pyrazinamide 25 mg per kg. But rifampicin and isoniazid, you can give the daily routine dose, and no dose adjustment is required. And another precaution that you have to take very cautious is that the ATT has to be given either 4 to 6 hours prior to the dialysis or immediately after the hemodialysis to prevent the washout of the drug. And a TB patient with a chronic liver disease, you need to calculate the child score or the MELD score has to be calculated based on the serum bilirubin, maybe albumin, INR, the hepatic encephalopathy or ascites, and you have to calculate the CTP score. And if it is child A, you can give 2 hepatitis drugs, and you have different regimens with the 2 drugs, but you have to give a longer duration. That is 9 months of INH rifampicin ethambutol, or you can give HRE with streptomycin and leoflox along with 6 months of HRE, and or you can give 6 to 9 months of rifampicin, pyrazinamide, ethambutol. These are different regimens that can be given with the 2 hepatitis drugs. And if it is a child B, it's a moderate disease, you can give only 1 drug, 1 hepatitis drug. In that scenario, you have 2 other regimens available. And if it's a child C, that is very severe disease, you can't give any of the hepatitis drug. You can't give INH rifampicin and pyrazinamide, and you have to give a purely safer drug. And so it may be a the SLE regimen, that is streptomycin, levoflox, and ethambutol, but you have to give a longer duration, that is maybe 18 to 24 months if it is a child C. And all those patients who are having simple hepatitis virus that just has SBSAG positive or a past history of acute hepatitis and a current alcoholic, they can give receive the usual ATT provided there is no evidence of chronic liver disease. The full dose ATT can be given until you need to just monitor the LFT only. And TB and diabetes should be very cautious. You have to do a bidirectional screening. All the diabetic patients should be actively screened for tuberculosis whenever they have the symptoms, and all the patients, TB patients who are diabetic, have to have a strict glycemic control with strict monitoring of anti-TB medications, anti-diabetic medications for a better treatment outcome. We all know that most of the patients will be on OHA and insulin, but they will not monitor the blood sugar status, and they'll be having uncontrolled blood sugar, and which leads to a poor delayed outcome. That is a poor smear conversion and delayed the treatment success of the TB is also very less with the uncontrolled diabetes. Now, HIV and TB co-infection. A patient who was diagnosed to have TB, if is found to be HIV positive, you need to start the patient first on ATT, and then within 2 weeks of starting ATT, regardless of the CD4 count, you have to start on ART. But if the patient is a case of TB meningitis, then the ART should be delayed for at least 4 weeks, and then you can start after 4 weeks. That is to prevent the development of IRIS, immune reconstitution inflammatory syndrome. And dolutegravir based regimen is a preferred regimen, and as the rifampicin is a enzyme inducer, cytochrome P450 enzyme inducer, you may have to give an additional 50 milligram of dolutegravir if the patient is on DTG based regimen. And if the patient is being started on the ART with protease inhibitors, then the rifampicin has to be replaced by rifabutin. So if there's a scenario that the patient is already retropositive, that is, he is already on ART regimen, and now he is diagnosed to have ATT, diagnosed to have TB, is that an ART failure? So what are the things that has to be considered? The first thing is if whether the patient has developed TB within the first 6 months of starting ART, then it is usually is unlikely to be a failure of ART. It's mostly due to an IRS. That is, patient is already sensitized to TB. There is an antigen sensitization. Now, after starting the ART, his immunity has improved, and the patient has manifested as TB. And if the TB is occurring after 6 months of starting ART, then probably it can be a treatment failure. But you have to assess the CD4 count, viral load, and the clinical status of the patient, and decide on changing the first line ART to second line ART. Now, that was regarding the special situations. Now, the monitoring of the TB patient. You have to do a clinical monitoring of the TB patient every 2 weeks. That has to be done by the medical officer itself. It has to be a clinical checkup, not through the phone by the STS or the JHI. You have to clinically follow the patient. It's very, very important, because in the coming slides, I'll be discussing that why it is important. And you also need to do a sputum follow-up as well. And the sputum follow-up has to be done at the end of intensive phase and as well as at the end of continuation phase. And X-ray, if it is required, you can repeat at any point of time. And weight has to be recorded monthly to assess the clinical improvement as well. And the patient, after completing the treatment also, you need to follow up the patient for the next 2 years, both clinically as well as if the patient is symptomatic, you need to do the sputum examination also. That has to be done every 6 months. That is after completion of ATT. That is 6th month, 12th month, 18th month, and 24 months. Up to 2 years, you have to keep the patient under follow-up, because there is a high chance of relapse in the first 2 years of post-treatment. Now, just a slide on the differentiated TB care model. This is actually the new concept. This concept came to play because our TB mortality rate is a bit high. I've discussed previously also. Our first of all, our case detection, actually there is a delay in the diagnosis of TB. By the time the patient is diagnosed, most of the patients will be in the advanced stage with a severe lung damage and all. That is one scenario. And the scenario is most of the patients will be having multiple comorbidities, maybe diabetes and maybe some immunocompromised situation, or chronic kidney disease, or a end-stage liver disease, or a heart disease. So multiple comorbid situations may be there. So you can't treat all those patients with the same manner. So you should have a you should do a triaging. That can be done with either the clinical parameters, important vital signs, and also the basic investigations like your LFT, renal function, the electrolytes, all has to be done, and you have to triage the patient. And assess what is the severity of the disease, and also to assess the comorbid illness as well as the risk of the adverse effects. And after triaging, you need to decide whether the patient can be managed as an OP, or whether he has to be treated as inpatient, or he has to be in a critical care setting. So that is the differential TB care in a nutshell. So the key elements is, first of all, triaging of the patient, the severity as well as high risk category, then referral to the appropriate health facility, and that this has to be reviewed in every visit. That is not at the time of diagnosis alone. Every time the patient is clinically reviewed, that is every fortnightly, you have to update this clinical monitoring. And if at all it happens that the patient a death occurs, you have to do a social autopsy also. That means it's not a simple death audit. You have to look into the social factors that has led to the TB death. Maybe whether it's a delayed diagnosis, or there's some other factors, socioeconomic factors that has contributed. All those factors has to be checked in while doing the death autopsy. Death audit, sorry. So this is in a nutshell the differential TB care approach. You are triaging the patient with all the all the important monitors, that is respiratory toxin saturation, the body BMI, beat and all. This can be done by the health worker. If the triage is positive, he'll be referred to the appropriate referral center, maybe the second center of tertiary care center. If the triage is negative, then he can be assessed at the peripheral institution with all the vital markers. And if he's fit to be managed in the OP basis, he can be followed up with the Ayushman Arogi Mandir or the PHC with a simple follow-up, usual follow-up. But if at any point in time, if he is not responding, or he is coming into the higher risk group, he has to be referred to the concerned higher facility and the managed approach. So this is a differentiated TB care approach, which has to be updated every 2 weeks in the NICSHE as well. So coming to the adverse drug reactions with TB, just a rule of thumb. Always when there's an ADR, you just first recheck the dose of the drug. Then you have to exclude other causes, whether there's some other cause for this particular symptom. Then assess the severity of the adverse effects. Always document the adverse effects. And if you can find that offending drug, you first need to stop the drug. And once the issue is settled, you can gradually reintroduce the drug one by one. So this is a rule of thumb for management of ADR. So the common adverse drug reactions, you all will be very familiar, that isoniazid acid causing peripheral neuropathy, hepatitis, the rifampicin with the hepatitis, nausea. But you can also have life-threatening situations like pseudoadrenal crisis, where the patient may require steroid therapy, and acute tubular necrosis and hemolytic anemia. When this occurs, the patient need not, it's an absolute contraindication for restarting rifampicin, and he may also have developed thrombocytopenia. That's also a contraindication for restarting rifampicin. And then pyrazinamide, it can cause the arthritis, hepatitis, and all. And ethambutol leading to the retrobulbar neuritis, optic neuritis, leading to decrease in the vision. And also sometimes peripheral neuropathy can also happen with ethambutol. So these are the common adverse effects that is seen with the first-line anti-TB drugs. So just a briefing on the common ADR management. Usually encounter symptoms with the nausea and vomiting. We can advise the simple steps like avoid taking all the drugs together, take the drug with little water, maybe with a light meal. And also you can advise antiemetics and proton pump inhibitors just half an hour before the drug. But always you should be very careful that a patient who is refractory to such routine management, you have to roll out a drug-induced liver injury, and LFT has to be sent a patient who is not responding to the usual line of management. And if the LFT is raised, you have to roll out other causes, maybe like a coexisting viral hepatitis. Maybe you have to send for the viral markers, hepatitis A, B, C, and all has to be sent up. Then autoimmune hepatitis has to be rolled out. Maybe it is a disseminated TB with the granulomatous hepatitis with the transient elevation of transaminases. After ruling out all of the causes, then you can consider the possibility of a drug-induced liver injury. Then you need to see whether if the enzymes SGA2PT is less than 3 times upper limit normal, then you just need to follow up the patient with LFT every 2 weeks. You needn't stop the treatment. But if the LFT is raised more than 3 times of upper limit of normal with symptoms, or more than 5 times of upper limit of normal without symptoms, that is more than 3 times means it's around 120, more than 100 or 120. More than 5 times will be around maybe 40 into 5 will be around maybe around 200, more than 200. Then even without symptoms, you have to stop the treatment and withdraw all the hepatitis drugs and wait for the LFT to become normal, that is less than 2 times of upper limit of normal, maybe less than 80. Then if the patient is very sick, you can consider giving the non-hepatotoxic drugs like aminoglycosides and ethambutol, like streptomycin and ethambutol. You can start, and once the LFT becomes normal, you can consider restarting, reintroducing drug one by one, maybe every 4 to 6 days. You can start with rifampicin, and then followed by INH and pyrazinamide. You have different approaches for challenging the drugs. Maybe you can give one drug with gradually escalating doses, like 150, then increasing to 300, then 450. That is what the BTS guidelines recommends. Or you have the ATS, American Thoracic Society guidelines, which recommends that you can give all the full dose at a single hand. And also, you can also consider starting all the drugs together. And some meta-analysis has been done on all these practices, and it has found that even if you give the whatever be the modality, whether you give the full dose at a straight or you gradually escalate the dose or give the full FTC, the chance of redeveloping the DILI is almost the same. So it doesn't matter how you challenge. You can opt for whatever method you can do. All are been approved by the various guidelines. Now, the management of itching or rashes, always you have to rule out other causes like scabies, the other environmental agents or drug allergy. And sometimes the elderly patient may be a simple as ectotic skin. You can apply the moisturizer. The mild rashes, you can opt for oral antihistamines. But still, if this is a very severe issue, then you have to stop all the drugs. And when there's a mucosal involvement, there's a fever or hypertension like that, then you have to add maybe the patient request steroids as well. And once the reaction subsides, then you can try reintroducing each drug in a small dose and gradually increase every 3 days before introducing the next drug. So one by one, you have to start and you have to gradually escalate the smaller dose. And only after 3 days, you have to start the next drug. So never attempt re-challenge when there is a Steven-Johnson or toxic epidermal necrolysis. Now, this is just a model of how you challenge the drug one by one, and the new drug has to be challenged only on the every 3rd day, maybe gradually increasing the dose. Just a model of how you do it. Then the common symptom, the arthritis, arthralgia, and or hyperuricemia, the culprit drug being pyrazinamide. And asymptomatic cases you needn't treat. But you have to properly hydrate the patient to prevent the renal stones. And symptomatic cases you can treat with NSAIDs, colchicine, and febuxostat. But if it is refractory, even with all this management, if the patient is not responding, you may have to consider the dose reduction of pyrazinamide. But usually the symptoms will resolve once the patient is started on continuation phase. In the continuation phase, you don't have pyrazinamide in the regimen. And the peripheral neuropathy, the usual culprit drug being isoniazid, you can increase the dose of pyridoxine to 100 mg daily. And if it's a refractory case, you can try for amitriptyline or gabapentin, pregabalin like that. Also, you can get a neuro opinion. And the most important thing, the impaired vision, the culprit drug being ethambutol. Also, you have to rule out other causes like diabetic neuropathy, retinopathy, and all. Cataract, also everything has to be ruled out with a ophthalmic opinion. And if it is proven that it is due to ethambutol, it can have various presentation, maybe decrease in the visual acuity, or can be color vision defect, or it can be field of vision defect. All this can be the presentation. But if it is confirmed that it is due to ethambutol, you never try restarting the ethambutol again. So that was about the ADA management. And now the treatment interruption, how to manage. So you need to consider what is the type of the case, whether it's pulmonary, extrapulmonary, what are the duration of treatment that has been taken by the patient till date, and also you have to consider the duration of interruption. If the patient has taken interrupted treatment for only less than 1 month, you can continue the same treatment. But if it's interrupted for more than 1 month, then you have to repeat the drug sensitivity test to rule out drug resistance, and then only consider restarting the regimen. Now, the treatment outcomes that has been followed in the program is the various definitions being cured, treatment completed, failure, lost follow-up. That is, cured means you have an end of treatment, the patient is have a microbiological negativity, and treatment completed means that there is no sputum testing has been done at the end of treatment with either smear or a culture, but the patient has completed treatment and there is a clinical resolution, his treatment is completed. And failure means at the end of treatment, the sputum is remaining positive. And lost follow-up means a patient who has interrupted treatment for more than 1 month and now has come back for treatment. And regimen changed means the patient who has been diagnosed as a DRTB and the regimen has been changed, and death due to any cause is taken as an outcome due to TB death in NTEP program. Now, with all these efforts, our drug-sensitive TB treatment success has increased from 69% to 88% now. So, by implementing our newer differential TB care concept also, I think we can still improve it to more than maybe 90-95%. Now, just a slide on, even though the patient has completed the treatment, he has been declared cured, the treatment is negative, the sputum is as negative, most of the patients will be having multiple morbidities. Maybe this patient may be still having symptoms. So this is an article which is published in the recent May 2025. There's a European Respiratory Review Journal regarding the post-TB morbidities and mortalities. And the study just shown that the symptoms, they have followed up the patient after treatment for almost 1 year, and even though the symptoms of dyspnea, cough, the sputum production, everything has come down, most of the patients still having the symptoms for persistent symptoms even after the completion of TB treatment. And regarding the lung function also, the most of the patient had compromised lung function, either in the form of an obstruction or if it's extensive fibrosis, then there's a possibility of a restrictive pattern also has been demonstrated in this particular study. And this is a CT pattern post-treatment. You can see that before treatment is red, that's after treatment is blue. You can see that this pleural thickening, this emphysema, then the green bud pattern, nodules, these are all persisting even after the completion of the treatment. So this is such post-TB lung changes can still be there. This will be more worse if the patient is having if you make a delayed diagnosis. I was discussing it in the first slide itself. If you don't suspect TB and you make a diagnosis at a very late stage, the patient will be having post-TB lung changes, and he will be having a lifelong disability. And so that is the importance of diagnosing TB early. Now, they have assessed the pulmonary morbidities, extrapulmonary morbidities, and the non-medical consequences as well as the mortality. And the pulmonary morbidity, the patient can have COPD, post-infective COPD is described in the literature. And you can also have fungal infections like chronic pulmonary aspergillosis, bronchitis with plenty of sputum production, hemoptysis, and patient can also have asthma-like presentation, and lung cancer, mostly the adenocarcinoma type. And you can also have recurrent infections like pneumonia and bronchitis. And if it's an extensive lung damage, the patient can go in for pulmonary hypertension and even poor pulmonary. And extramorbidities morbidities that have been described as various forms like MI, ischemic stroke, all this has been very it's higher than the usual healthy people in a post-TB patient. And the mortality also, the causes of mortality, even infectious disease, respiratory disease, and cardiovascular cause of death is also very high among post-TB patients. This was that was projected in the ERS study published recently. Now, they have come forward with the points for clinical practice. That is, the post-TB morbidities and mortalities are very significant, in which COPD, the chronic pulmonary aspergillosis, and bronchitis, lung cancer are the significant primary challenges. And this residual lung structure damage and prolonged inflammation after TB treatments are important risk factors. And so we have to develop host-directed therapies and pulmonary rehab to reduce the lung structure damage, improve the lung function of these patients, and you have to adopt a well-tailored preventive strategy and screening protocols for preventing such situations. So this has to be this is the one future research perspective. So you have to, in addition, usually pulmonary rehab is described for COPD patients. Now they have suggested it for post-TB patients as well. Now, this is a document that has been released by the Government of India for certifying the TB patients as non-infective. This I have projected only for drug-sensitive TB. So a patient who is having a non-extensive, non-cavitatory pulmonary TB, he may be declared non-infective if he has taken a treatment for almost 2 to 3 weeks of regular compliant medication, and there is no evidence of clinical worsening and radiological deterioration. You can do 2 sputum samples at 7 days apart, and if the 2 sputum samples are negative, you can declare it as non-infective. But if one of the sample is positive, then you have to repeat the procedure again after some days, and then if both are negative, you can declare as non-infective. And if it is a bilateral disease, extensive disease, and a cavitatory TB, then the patient has to take at least 5 weeks of regular treatment, compliant with medication, adherent to the treatment, and there should not be any evidence of clinical worsening or radiological deterioration. And again, the same thing, you have to take 2 sputum samples, smear is sufficient, which is taken 7 days apart, and if both are negative, you can declare as non-infective. So this is an important thing most of us will be facing, and the patient will be asking for certificate to rejoin the service. So this is directive from Central TB Division issued on 30th May 2025. This you can follow very well. Now, these are the changes in the management of TB that has occurred till date, right from the abolishing of Category 3 in 2010 to the introduction of the new BPALM regimen in 2024. And we have started in Kerala in March 2020. Our first case has been successfully treated and declared cured last month. So this is the regimen treatment management changes that has occurred till date after the starting of the TB control program. Now, just a slide on the WHO, ATS, CDC, ERS guidelines, which was released recently. Actually, this, as the talk was the update on DSTB treatment, I've just put the slide up, but it is not been adopted in our program. NTEP program has not adopted this. So please mind you, this is just the latest guidelines that was released by the WHO and ATS. We are not following it in India right now. Maybe in near future it may come. I'm not sure. So just to show this slide, as it is a recent update, I have included this slide. So you have a 4-month regimen for drug-sensitive TB. That is 2 months of H is isoniazid, P is rifampicin, M is moxifloxacin, and Z is pyrazinamide. So 2 months of INH rifampicin, moxi, and pyrazinamide, followed by 2 months of INH rifampicin and moxi. That's total of 4 months treatment. This is suggested for patients more than 12 years of age. And the regimen is for the children in the age group of 3 to 16 years with non-severe TB. That is, there is no extensive cavitating disease. It's an only unilateral disease, a lobar disease, and is not smear positive. And otherwise, extrapulmonary TB means maybe it's only peripheral node. There is no extensive mediastinal nodes and other CNS involvement. Disseminated TB, nothing is there. It's a simple non-severe TB. Then these children can be considered for 4-month regimen with 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, followed by 2 months of isoniazid acid and rifampicin. This is for children less than 16 years. That is non-severe TB. But if it is a severe TB, you have to resort to the standard 6-month regimen that we are following right now. So this is the guidelines that has been come up recently, but it is not followed in India, not adopted by NTEP right now. So please make it a point. So this is a UN target that has been UN high-level meeting target that is set for the 2027. We have only 2 years left. So the expectation is that we should resort to 100% NAT testing by 2027. And the TB treatment coverage, now it is only 75%. We have to improve it to 90% by 2027. And the TB preventive treatment coverage, that has to be increased to 90% by 2020. This is what is being expected. And the TPT coverage for household contacts, now it is very low. It is only 21%. They have to increase it to 90% by 2020. This is the UN target that has been set for 2027. So this is regarding my presentation. Thank you for the question listening.
Thank you, Dr. Neena, for the very extensive and elaborate talk covering all the aspects of TB management. If there are any queries, you can just unmute and ask. One query is the chat box: ophthalmic evaluation and records needed before starting with ATT in confirmed PTB cases. How frequently ophthalmic evaluation done through IP and CP phase, intensive phase and continuation phase?
Can you repeat the question? It's not clear.
You can just check the chat box also. It's ophthalmic evaluation and records needed before starting with ATT in confirmed pulmonary TB cases. Dr. Estes, you can just unmute and directly ask.
Actually, what we suggest is that if there is elderly patient, diabetic and all, it's always better to go for an evaluation before starting ATT, because he may be having already compromised vision. So if once you start the ATT and after that the patient is complaining, we will not be able to differentiate whether it is due to drug-induced or it was there. So it is better to go for a evaluation. But for that evaluation, you need wait to complete that evaluation and start. You can start the treatment and just simultaneously you can do the ophthalmic evaluation as well. Ideally, the one question is whether the anti-TB drugs interact with food. Is there an ideal time for consumption? Actually, what we advise is that actually the empty stomach is better for the absorption of the drugs. But what is usually happening is when the patient takes it empty, in an empty stomach, there will be high chance of developing gastritis. Intolerance is very high. So what we advise is you can take it with a light meal and then take. And always it's better to take in the morning hours rather than in the night. And most important thing is you have to take the drug together. Not like usually I've seen many prescriptions taking like paracetamol in the morning and then in the evening ethambutol taking in the afternoon. That AKT4 and 4-COX. I have seen many prescriptions like that. That is not advised.
Maximum within 20 minutes.
One question was like, even with this intensified case finding, we could only reduce the incidence only by 16%. Actually, this is the real scenario. This is the data which is there in Indian TB report last year. So that's why I was discussing that you need to, even if we all know that the presumptive TB symptoms is cough, 2 weeks, cough and fever for more than 2 weeks. Every child, even if you ask the MBBS students, they will be telling this, but in practice, they are not doing. That's the real scenario.
Good evening, madam. What about empirical ATT treatment? Is it still practiced or what? Empirical ATT treatment.
Actually, we can't use that word empirical. I've described, no, you have to make an attempt to confirm it microbiologically, whether it is pulmonary or extrapulmonary. But if it's not possible, you have other methods, like maybe if it is a respiratory case, respiratory symptoms, you can go for an X-ray, you can go for a CT. You have if there's facility, you can go for a bronchoscopy and BAL. Every attempt has to be made for a microbiology confirmation, but still it is possible. You think that other alternative possibilities are not there, then you can treat it as clinically diagnosed TB. There is no word like empirical ATT. You can make it clinically diagnosed if it is not microbiology confirmation.
Okay, thank you.
But you have to document whatever if you have reached a particular you have decided to treat that patient, you have to document on what basis you have made the diagnosis. That is very important, because if the patient you are making the clinical diagnosis like based on X-ray or CT, or maybe if it is a lymph node based on FNAC or a excision biopsy report, and after starting the ATT, the patient develops some drug-induced liver injury or a skin rash, and the problem occurs then only. If you have ruled out all of the causes and it is the most probable diagnosis TB, you will be very safe if you document everything. Otherwise, the patient can, there's high chance that he can sue for wrong diagnosis and treatment.
That's what. Thank you, madam. Thank you.
Any other questions? Harsha sir, any concluding remarks from your side?
Very exhaustive presentation. That's good. And some points had to be stressed. That concluding that those slides regarding that change, etc., were very nice, and so everything was in a gist in those slides. So nothing more. Praveen, Dr. Praveen.
Okay. Okay. Dr. Abhilash, any comments from your side?
വളരെ എക്സലന്റ് സെഷൻ ആയിരുന്നു. നമ്മളിത് സെൻസിറ്റീവ് നമ്മൾ കുറച്ചുകൂടെ പാർട്ടിസിപ്പേഷൻ തീർച്ചയായിട്ടും നമ്മുടെ എംഒസിന് വേണം, പ്രത്യേകിച്ച് ചേഞ്ചസ് എല്ലാം. ഇതൊരു ഡയബറ്റിക് കൺട്രോളൂടെ നമുക്ക് ആഡ് ചെയ്യുവാണെങ്കിൽ നല്ലതായിരുന്നു.
Okay, thank you. The recording will be uploaded in the YouTube channel, so this can be used as a reference. So this was very extensive, as I already said. So if there are no more, Krishna എന്തെങ്കിലും പറയുന്നോ? കൃഷ്ണ? Srijit? Okay, so there are no more comments. I think we can conclude the meeting. So from the coalition side, I thank Dr. Neena for the very extensive talk. And also thank Arshad sir and all other participants for the meeting. Second one, ഇടയ്ക്ക് join ചെയ്തിട്ട് പിന്നെ leave ചെയ്തെന്ന് തോന്നുന്നു. Okay. So
Thank you.
Thank you. Thank you.
Thank you. Good night. Closing the